Good evening, friends. Today I'll be talking about the ultrasound of the salivary glands. So to start with, why ultrasound? So in Europe and Asia, ultrasound is widely accepted as the first imaging method of assessment of the lymph nodes or any other soft tissue structure in the head and neck, which includes the major salivary glands. Whereas in the US, they consider CT as the best method for assessment of inflammatory disease, and MR imaging for the single method for assessment of the tumors related to the salivary glands or any other soft tissues. But we are here to conclude that ultrasound may be a supplement both for both CT and MR imaging for the superficial salivary gland lesions. So what are we going to discuss today? This is a brief list of what I am planning to discuss. First, we'll start with basically a small note on the anatomy of the major salivary glands. Then ultrasound features of the most common pathological conditions, starting from the inflammatory disease to the neoplasms. So for any ultrasound, technique is very important. So just a brief note on the technique. Like any other superficial structures or small parts of the body, the ultrasound of the major salivary glands also has to be done with a highest frequency transducer. Usually the frequency that we use is between 5 and 12 megahertz. Most commonly, the median frequency is used, that is 7 to 7.5 megahertz. Whereas for tumors which are large or located in the deeper structures, a lower frequency transducer, which is somewhere around 5 to 10, 5 ideally, should be used. And when we want to see the finer detail or the internal structure of salivary glands, we can go to a higher frequency, something like 10 or more than that. So in the basic scanning technique, we should always keep in mind that not only the salivary glands should be imaged, but also any other lesions like a fluid collection or associated lymph nodes all need to be documented and evaluated at least in 2 perpendicular planes. This applies to any imaging related to ultrasound. Then coming to the brief note on the anatomy, we'll just discuss about the anatomy of the 3 major salivary glands, namely the parotid, submandibular, and sublingual glands. Parotid gland is located in the retromandibular fossa, just anterior to the ear, and has got 2 lobes, namely the superficial and the deep lobes. The deep lobes, the lobe is not always accessible and not completely accessible for ultrasound examination. Most of the lesions which are related to the superficial lobe can be easily diagnosed. So basically, the landmark that we use for the parotid gland anatomy for the differentiation of the superficial and deep lobes would be the retromandibular vein and also the external carotid artery. So this is the ultrasound image where you can see the transducer placement just below the ear transversely. The right parotid gland demonstrates the mastoid process, the mandible, the superficial lobe, and the deep lobe, which is the landmarks would be the vein and the artery, the retromandibular vein and the external carotid artery. The same when done in the longitudinal plane. So this is a panoramic view of the salivary gland with also a pictorial demonstration of the structure seen on the panoramic view. Basically, this would be the salivary gland with the landmarks which were the retromandibular vein and the external carotid artery, the ramus of the mandible there, the masseter sitting over that, and also the muscles, buccal mucosa, and some amount of air mixed with saliva may be seen, and the reverberation artifact from the mandible. And other thing that we commonly see is a normal lymph node or intraparietal lymph node can be seen. The criteria would be to call it normal would be the ratio would be at least the width is at least twice as the depth, or by millimeters it should be 5 to 6 millimeters. Anything which is beyond 6 millimeters should be viewed with suspicion for any other cause like inflammation or mass. And it's important to know about the anatomy of the Stenon duct, because we know that one of the common ultrasound indications for the ultrasound would be to rule out Sialosis. So this is a pictorial demonstration and also the actual image, a panoramic view, which shows the salivary gland there, the parotid gland, and the duct, which is somewhere around 3 to 5 centimeters. About 1 centimeter of the duct passes on the masseter and can be imaged by keeping the transducer transversely just about 1 centimeter below the zygomatic arch. So the duct terminates at the level of upper second molar into the papilla. That is the gland there, and the two is the duct, and of course the second superior upper second molar, and the mandible there, and the masseter muscle. So this a normal non-dilated duct may not be possible to detect even with high resolution, but there are few authors who say that a normal duct can be visualized with the currently available machines. From my experience, till now what I have seen is only the dilated duct because of the obstruction. This is the duct that we can see there. Marked is the mandible, and you can see a small calculus sitting at the distal part because of which the duct is dilated, and of course the landmarks are always to be seen. And then the submandibular gland is basically a triangular shaped gland which is located in the posterior triangle or the posterior submandibular triangle. The digastric muscles form the anterior and posterior margins and also the mandible. So either in transverse or in longitudinal view, we see that the gland appears to be triangular in shape, and we may also be able to see the tortuous facial artery passing through, which can act as a landmark. So this is the gland there, the facial vein and the facial artery passing through the tongue, tonsil, and the muscles, namely the mylohyoid and the hyoglossus muscle. And again, the duct is very important because more commonly the Wharton duct is involved in Sialosis than the parotid duct, the Stenon duct. The Sialosis is more common in the submandibular gland duct, which we see more commonly on CT scans. Probably many times it can be an incidental finding. Coming to the anatomy of the duct, this is the submandibular gland there, which is just the duct passing just over the mylohyoid muscle. That is the sublingual gland, and opening just inferior to the tongue there. Sublingual gland is a smaller gland which is just medial to the oval-shaped gland, just medial to the mandible, in between the muscles of the oral cavity, floor of the oral cavity. So before going to the pathology, we need to know that the echogenicity of the salivary glands are just higher, or it's hyperechoic as compared to the surrounding muscles because of the fat content. And many times we see that the more the fat content, it may be very difficult for us to look at the landmarks, namely the retromandibular vein, the external carotid artery, or the deep lobe of the glands. So to start with the lesions, acute inflammation, which is the most common indication for us to look for in the ultrasound department, because the patient comes most commonly with a swelling of the face, where either it could be unilateral or both the glands may be enlarged. So acute inflammation presentation would be with a pain and swelling of the face, and ultrasound findings would be the gland. We see that the parotid gland or with any other gland involved would be enlarged and hypoechoic, and most of the times we see that the echo texture is inhomogeneous and may contain small oval hypoechoic areas. And typical of any acute inflammation, we see that it is hypervascular and enlarged lymph nodes, either cervical lymph nodes or intraparotid lymph nodes itself. And also with a high resolution probe, a transducer, we may be able to see the central flow which is increased. So acute inflammation, we see here that there are multiple, as compared to a normal gland. So it is ideal for us to, if the complaints of the patient is one-sided, unilateral, then it's always better to compare the gland with the contralateral side, so that we easily make out that the echo texture is different, and also it is edematous or enlarged, and hypoechoic areas, of course, can be seen with hypervascularity. Another image where the comparison is made is the right gland, the left gland. Clearly, the gland is enlarged, hypoechoic, multiple hypoechoic areas, hypervascular, and enlarged intraparotid lymph node. Then comes the chronic sialadenitis. It's usually the symptoms would be intermittent swelling of the gland and on and off pain, and the pain may be associated with or without. At the time of having food, the pain may increase in few patients. So the difference between acute and chronic sialadenitis is that the gland may be normal in size or smaller, and the echo texture would be hypoechoic and inhomogeneous. And typically we see that the blood flow is not increased. It's not hypervascular as we see in the acute stage. So this is image of the bilateral salivary glands with chronic sialadenitis, where we see that the gland is hypoechoic, heterogeneous. We don't see the typical hypoechoic foci that we see in the acute, because it's more of a diffuse heterogeneous echo texture. The gland is smaller. A few times we may see that there can be small calcific foci, and no hypervascularity. An acute inflammatory process can give rise to an abscess prolonged without treatment or with other factors like obstruction or immunocompromised status. So an abscess is like an abscess in any other part of the body, where we see that there is a heterogeneous echo texture with a central liquefaction is there without flow, and there can be layering or the internal motion of the fluid contents, thick fluid contents that we see in any other abscess. And typically we see that clinically an abscess may not be diagnosed, is not easy to diagnose. So an ultrasound would be the easiest and the best modality for the diagnosis of a abscess, particularly the parotid abscess. And also there can be, sometimes we see that there can be gas lobules that can be seen within the abscess. Another example, there is a small focal abscess surrounding hypervascularity, but there is liquefaction at the center without any vascularity. And the next would be the sialolithiasis. One of the commonest indications would be the for the inflammation would be an obstruction of the ducts. So the submandibular gland is the one which is most commonly affected, 60 to 90% of the cases, and the stones may be multiple in the duct, Parotid glands are affected only in about 10 to 20%. So it's very less common as compared to the submandibular gland. And ultrasound, in cases of is the modality of choice, at least to start with, in cases of clinical suspicion of sialolithiasis. Typically, to see the dilated duct, many times if the calci are less than 2 to 3 millimeter, it may not be visible or it may be doubtful. Then, of course, the standard technique would be the digital sialography. But since it is a invasive technique, now most of the departments have started using the non-invasive MR sialography. It's a submandibular gland, left submandibular gland, where we see that the gland is hypoechoic and heterogeneous because of the second inflammation. That's the calculus and the dilated duct there. Then the transverse image clearly depicts a large calculus with the dilated duct. We should be careful not to confuse the air bubbles, sometimes the air efficiencies, which have a dirty appearance as compared to the clear aftershadowing which is seen in the calculi. That's some of the pitfalls that can be mistaken for sialolithiasis. And sialosis is a condition where a patient presents with swelling of the salivary glands, but on ultrasound we don't see any signs of inflammation. So sialosis is basically a non-inflammatory, non-neoplastic, recurrent, painless salivary gland swelling. Most often seen, at least I have seen few patients who come with a salivary gland swelling without any pain, and we cannot really explain what could be the reason for the swelling. But this is a lesion which is categorized as the sialosis. So usually bilateral. Most often the parotid glands are inward, and they can be described in connection with other pre-existing diseases like the endocrine disease, malnutrition, hepatic cirrhosis, chronic alcoholism, or different deficiency diseases. So this is a condition where once we give the diagnosis of sialosis, probably other the test needs to be done to rule out any of these. So ultrasound, on ultrasound we see that the glands are enlarged, hypoechoic, because of the enlargement, and also hyperechoic echogenicity, and also because of the enlarged gland, the deep lobes may not be clearly visible, and also there won't be any focal lesions or increased flow. So this is the one which helps us differentiate, apart from the clinical symptoms that the patient doesn't have fever or pain. By ultrasound we see that there are no focal lesions or hypervascularity. So Sjogren Syndrome is a chronic autoimmune disease where there is dryness and of the salivary glands and the lacrimal glands. Predominantly it affects women over 40 years of age, and the major clinical symptoms include dry mouth and eyes. So it can affect all the salivary glands. Ultrasound features would be an inhomogeneous structure of the gland with scattered multiple small oval hypoechoic or anechoic areas, usually well defined, and there can be increased parenchymal blood flow. So usually we see that it's a bit, sometimes it can be challenging to differentiate it from an acute inflammation, but we see that the gland is not enlarged, but the echo texture, as we see the acute inflammation, here also it's inhomogeneous and there is hypervascularity. So for any lesions which exceeds 2 cm, biopsy would be recommended, or any lesion which is fast growing, to rule out the malignant potential it has got. So this is a Sjogren's syndrome image which is very much similar to the acute inflammatory changes, except for the clinical presentation is different, and also the gland is generally not enlarged. So now we'll briefly go into the neoplasms. Neoplasms are rare in the salivary glands. Most of the lesions, majority of the lesions, the neoplasms that we see in salivary glands, up to 70 to 80% are benign lesions, fortunately. Majority of the lesions are seen in the parotid glands. That is 80 to 90%. A major chunk is seen in the parotid glands, and only about 10 to 12 in the submandibular or the other salivary glands. But out of these 10 to 12%, half of the neoplasms may be malignant. So a broad classification: neoplasms would be the benign and the malignant. Benign lesions, most common is the pleomorphic adenoma, and second most common is the Wharton tumor. Other benign tumors include the oncocytoma, basal cell adenoma, hemangiomas, lipomas, and then the malignant neoplasms. The most common is the mucoepidermoid carcinoma, followed by the adenoid cystic carcinoma. The lesser common are the squamous cell carcinoma, actinic cell carcinoma, and adenocarcinoma. So imaging wise by ultrasound, all that we need to say is whether the features are suggestive of benign lesions or malignant lesions. And if it appears to be malignant, of course, other modalities or invasive techniques needs to be followed to differentiate for the type of malignancy. So ultrasound may not always help us in telling what kind of malignant neoplasm is present, whereas it is more helpful to clearly say the imaging findings are better delineated to call the benign neoplasms into one category. So since the benign lesions are more common, I think it is better to stress more onto the details of the benign lesions. So pleomorphic adenoma, as you know, is the most common lesion, benign lesion of the salivary glands. Affects the parotid glands 60 to 90%, and there's a slight predominance in the females in the 4th and 5th decades. Usually, the lesion is solitary and unilateral, grows slowly, and may be asymptomatic like any other benign lesions. But there is a potential of malignant transformation after a few decades. And in few exceptional cases, it can be aggressive, where it can metastasize and even be fatal. But a very small percentage can still have this potential to metastasize and be fatal. So typically, the pleomorphic adenoma has a lobulated, hypoechoic, inhomogeneous ecotexture. They can be solitary, or a few cases we see that they are multiple, but the margins are clear-cut, lobulated, and a typical appearance can tell us that this is a pleomorphic adenoma. As you can see here with the multiple images, most of them are pathognomonic images where we can see that the lobulation is there and the margins are clear-cut, and there is a acoustic shadowing there. Acoustic enhancement there, and it's non-vascular. Typically, we see that rarely there are any vessels within the pleomorphic adenoma, and it can be either completely hypoechoic or heterogeneously hypoechoic. The second common benign lesion would be the Wharton tumor. 5 to 10% of all benign salivary neoplasms. Less common as compared to pleomorphic adenoma, and most often in men in the 5th and 6th decades. And there is an established relationship between smoking and Wharton tumor, usually solitary, unilateral, and slow growing. And 10 to 60% of the cases may occur bilaterally or multifocally. So by imaging, we see that ultrasound, we see that oval, hypoechoic, well-defined tumors. They have multiple anechoic areas, like something like a complex cystic appearance, and hypervascularized. So diagnosis typically can be done by technetium 99 centigram, where it is diagnostic when we see a hot tumor with increased tracer uptake. This is a image as the Wharton tumor, where we are seeing that there is a typical complex cystic areas are there with either they can be multiple or single, with the solid components having hypervascularity. There are other benign lesions which can be like any other soft tissues of the body, like a lipoma, which can be present anywhere, as a typical appearance of a hyperechoic fat-containing lesion, a panoramic view of the lipoma there. And then coming to the malignant neoplasms, the most common malignant neoplasm is the Mucoepidermoid carcinoma, followed by the adenoid cystic carcinoma. Less common other types of carcinoma are there, but as I told, differentiation or the type of neoplasm may not be the scope of ultrasound. So all that we need to say is to categorically say that if there is a chance of malignancy, then probably further investigation would be required either by invasive FNAC or probably MR imaging. Less than 30% of focal lesions in the parotid gland are malignant. So majority, like at least 60 to 90% of the lesions that we see in the parotid gland is benign, and the rest 10 to 12% of the lesions which are seen in the submandibular have half of them being malignant. So the lesions in the submandibular gland are more prone to be malignant. So better have a higher suspicion of malignancy in submandibular glands as compared to the parotid gland. So Mucoepidermoid carcinoma occurs mostly between 30 and 50 years of age, and ultrasound features are like the features of any other malignant lesion in any other organ, and namely the irregular shape, borders, blurred margins, hypoechoic inhomogeneous structure, may be homogeneous in and well defined in few of the patients where it can be really confusing to call it, or we may call it as a benign lesion and later on it can turn out to be malignant. There are few instances where it has been reported, and the internal structure of the malignant tumor may be solid, cystic, or there can be a mural nodule. So we see that there is a varied appearance of the malignant lesions depending on the differentiation of the carcinomatous changes in the cells. So there is no exact typical imaging finding which can say that it is definitely malignant, but the other imaging modalities like the CT or MR may be helpful when we see that there is enlarged lymph nodes or destruction of the surrounding structures. Maybe the mandible is eroded, or there can be destruction of the mandible or other osseous structures, which goes more in favor of malignant lesions. So once there is any suspicion of malignancy, probably ultrasound may not be enough. We always have to suggest for the further investigation with other imaging modalities. Metastasis, very rare, very uncommonly seen a site of metastasis. The salivary glands are very uncommon site for metastasis. Primary tumors usually are from the head and neck region. A tongue lesion can metastasize to a salivary gland. Or other distant lesions would be the melanoma, the breast cancer, lung cancer have also been reported to give metastasis to the salivary glands into the intraparotid lymph nodes. And a few extremely rare cases of metastasis from renal cancer has been documented in the literature. And lymphoma, primary involvement of only the salivary glands by lymphoma is very rare. Usually it is one of the site of systemic disease, and it manifests as painless progressive swelling, usually associated with other autoimmune diseases, most often with Sjogren Syndrome or rheumatoid arthritis. So ultrasound typically it's a solitary hypoechoic, homogeneous or inhomogeneous lesion, which can have a lobulated or irregular margins and has echogenic septa stripes within. But we should know that the features are not pathognomonic. So the diagnosis basically is not solely imaging of the parotid or the salivary glands, but it should be looked at a larger picture, where once we know that this patient is a patient of lymphoma where other organs are involved, then we should always any lesions in the salivary glands should be looked into with a suspicion of lymphoma, lymphomatous involvement of the salivary glands. Whereas if you see a lesion which is involving only the salivary gland, probably it is very rare that it primarily involves the salivary gland. So we see that there can be enlargement of the intraparotid lymph nodes, and then after the lymphoma, the other common lesions that we may incidentally see in salivary glands would be the cysts. Cysts, like, it can be present as a simple cyst or a complex cyst. Usually the cysts are formed because of the obstruction. Like in any gland, we see that the ducts may be obstructed because of the calculi or non-drainage. So they can form either a simple cyst or they can get secondary infected. So they can be just an incidental finding. And one thing we should also know that is just to take a note of is the effects of irradiation. Any head and neck patient who has taken irradiation can have complete loss of salivary function, and there can be what is called the xerostomia, the dryness of the mouth. So this is an example of a salivary gland which is almost atrophied because of the irradiation. The patient had received irradiation about 9 years back for cancer, oral cancer, and later on he developed dryness of the mouth because of the, and the gland typically appears like what we see in the chronic sialaginitis. The gland becomes smaller, and there's no flow, and typically we see that there can be echogenic bands because of the atrophic changes. So a small word on the traumatic findings. Trauma most commonly involves the parotid gland because the other salivary glands are hidden behind the mandible, and they are well protected, except unless there is a shattering injury. So parotid glands are easily accessible for trauma. The ultrasound findings are typically of any other traumatic lesions, like we can see a hematoma, fluid collections, or at a later stage we can see that there can be a fistulous formation between the parotid gland and the surrounding structures. And when there is a suspected damage of the facial nerve or to the Stenon duct, definitely we should not hesitate to go for the further investigation with a CT/MR or a xylography. So to conclude, ultrasound is a valuable and useful method for diagnosis of salivary gland diseases, particularly the superficial lesions or the major salivary glands, and because it not only helps us to confirm that there is a lesion, but at least in majority of the cases it also helps us to say what kind of a lesion, or at least to differentiate whether it's a benign lesion or a malignant lesion or an inflammatory lesion. So for the primary characterization, definitely ultrasound is a valuable tool. So that would be the take home message for the day. And these are my references. Hope the talk was useful, and I'm ready to take any questions if you have.